Welcome to Clinical Capsules from TRC Healthcare, your trusted source for practical, evidence based updates. On this episode, Associate Editor and Clinical Pharmacist Don Weinberger shares practical guidance on managing chronic obstructive pulmonary disease, COPD, including how updated guidelines approach inhaler selection, escalation of therapy, proper inhaler technique, and reducing exacerbation risk, in an excerpt from our popular Pharmacy Essential Updates webinar series. This podcast offers continuing education credit for pharmacists and pharmacy technicians. Please log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Catch new episodes of Clinical Capsules every second and fourth Tuesday, bringing concise, actionable insights from TRC experts straight to your ears. Let's take a closer look.
So let's talk about treatment and management for patients with COPD. And we're talking about this today because you'll see patients start daily maintenance inhalers sooner as part of those updated COPD guidelines on helping to better match therapy to symptoms, exacerbation history, and emphasizing non pharmacological options to help keep patients out of the hospital and breathing a little better. Okay, so let's go ahead and start off with a hospital case this time. We have Patty, and she was admitted to the hospital with a COPD exacerbation. You were called down to the ED to perform a medication reconciliation. When interviewing the patient, you discover the following: your inhaler, 2 puffs every 3 hours; tiotropium aldosterone inhaler, 1 puff every other day; propranolol 40 milligrams 3 times daily for heart failure. And looking at the social history, you see that she doesn't drink alcohol, but she does smoke 1 pack of cigarettes per day. You see any potential reason or reasons that could have increased her risk of a COPD exacerbation? Now, before we get started on COPD, I did look at the past comments that we had when we presented COPD, and a lot of people actually asked, what are the main differences between COPD and asthma? So let's go and get to that right out of the gate, because on the surface, they do look pretty similar, but the details tell a bigger story. Asthma often starts earlier in life and is driven by airway inflammation. It's commonly associated with allergic triggers like pollen and non allergic ones like exercise or illness. Key thing to remember is that asthma symptoms like shortness of breath, cough, and wheezing can vary day to day. And some patients, even improve as they get older. COPD, on the other hand, usually shows up later in adulthood. It's caused by progressive damage to the lungs, as we said earlier, most often from smoking or the long term exposures. Patients still have shortness of breath and cough, as with asthma, but they're more likely to have other symptoms, include sputum production, mucus, and those symptoms usually worsen over time rather than come and go with asthma. So, if a person has both asthma and COPD, how do you treat it? Well, both guidelines state to follow asthma rules first. Well, how do you find those? We have these great new charts on our website that you can go to. So please type in asthma on our website for more information. Okay, let's get back to the main event, which is COPD. When we think about treating COPD, it really comes down to two key goals: symptom control and risk reduction. So, starting with symptom control, this is what patients experience every day. Our aim is to reduce shortness of breath, cough, and wheezing and to help patients tolerate activity better. The other side of the target is risk reduction, which is just important, even if patients don't immediately feel it. Looking back at it, how many times has a patient said they don't take their meds regularly because they feel fine? In my experience, it's been quite a few. So here, the focus is on slowing disease progression and, importantly, preventing exacerbations, since each exacerbation increases the risk of hospitalization and contributes to long-term decline, up to mortality. So prevention is a major priority. Ultimately, effective COPD management means balancing both: helping patients feel better today while also reducing the risk of exacerbation and disease progression tomorrow. And if we think about the main buckets of inhaled medications for treating COPD, there are the short acting bronchodilators, which open up airways quickly, like albuterol and ipratropium. Next, we have the inhaled corticosteroids, like fluticasone, which reduce inflammation in those with COPD. And lastly, we have the combination, the PDE3 and PD4 inhibitor, like ensifentrine. So before you even start with therapy, make sure all patients with COPD continue to get short-acting bronchodilator like albuterol as needed to relieve symptoms, in addition to whatever maintenance therapy they are currently taking. So let's go ahead and take a look at how GOLD, which is the Global Initiative for Chronic Obstructive Lung Disease, their guidelines recommend for treating COPD initially. We're going to start with Group A. So Group A is the group with the mild symptoms, like the occasional shortness of breath or cough, and more importantly, no moderate or severe exacerbations in the past year. These patients are typically early in their disease and may not need that complex therapy yet. For this group, the recommendation is to start with a bronchodilator. So we have a short acting beta agonist, also called a SABA, or short acting muscarinic antagonist, also known as a SAMA, can be used as needed if symptoms are truly infrequent. However, the GOLD guideline makes it clear that long acting bronchodilators are generally preferred over short acting agents. So, for many patients, starting a long acting beta agonist, a LABA, or a long acting muscarinic antagonist, LAMA. This provides more consistent symptom control and reduces reliance on those rescue short acting inhalers. Let's put the microscope on those treatment options now. Short acting bronchodilators become used in COPD, primarily for quick symptom relief. Again, we have those SABAs, like albuterol. I love buterol, used for rescue therapy to provide that quick opening of airways. And we also have the short-acting muscarinic antagonists, or SAMAs, with ipratropium being the main example. This works through different mechanisms and can be alternative or addition to a SABA in COPD. Now, looking a little more closely at short-acting bronchodilators, these are medications we think of as rescue inhalers for COPD, typically used as needed on a daily schedule to help those with COPD symptoms like shortness of breath, wheezing, or chest tightness. Another key point is combination therapy, using a short-acting muscarinic antagonist like ipratropium together with a short-acting beta agonist like albuterol. For example, you know, products like Combivent or Duoneb may provide better symptom relief than either medication alone in some patients. And looking at long-acting bronchodilator COPD, we have the two classes, again, like the LAMAs and the LABAs, which include meds like albuterol or salmeterol. So it makes sense that these meds are used on a daily basis for maintenance, patients with persistent symptoms. Since they're long acting, then short acting bronchodilators. When we're talking about long acting bronchodilators, like LABAs or LAMAs, actual choice often comes down to practical factors, things like cost, payer coverage, and what's actually available. These medications are meant to be taken on a scheduled daily basis and not as rescue inhalers. Common counseling point is reminding patients they shouldn't expect immediate relief from a LABA or a LAMA, or at least not as fast as they would from a SABA or a SAMA. Also, if patients have asthma, LABAs cannot be used alone, since there also needs to be an inhaled corticosteroid like fluticasone with that LABA. We'll talk more about this later. For sudden or worsening COPD symptoms, patients should still rely on short-acting bronchodilator like albuterol for quick relief. So let's move on to our next group. So Group B is a lot like Group A, but they have more of the mild symptoms, so more cases of the breathlessness and cough, but still no moderate or severe exacerbations in the past year. For these patients, the first line therapy recommended is dual long acting bronchodilation, which means a long acting beta agonist, a LABA, and a long acting muscarinic antagonist like a LAMA. And all those combo LABA LAMA inhalers are equally effective. So if we look at the examples of LABA LAMA combos available, we can really suggest One mainly, again, on patient preference and payer coverage. And pretty much all of them cost at least $400 a month. But this is generally less than having two separate inhalers versus the combination. Okay, lastly, let's look at that last group, which is group E. These are patients with moderate to severe symptoms and at least one moderate or severe exacerbation in the past year. For most of these patients, you'll start them off with a LAMA plus a LAMA, like you did in group B. Now you'll notice the addition here, which is the inhaled corticosteroid, but that's not automatic for everybody. So ICS is added only if there is a clear indication. Specifically, the patient has concurrent asthma or a key inflammation indicator, such as a blood eosinophil count of 300 cells per microliter or higher. So inhaled corticosteroids are commonly used in patients on triple therapy, which includes that ICS plus a LABA plus a LAMA. These combination inhalers are effective, but they can be expensive, often costing $680 or more per month. Use luxury labels to communicate that patients should always rinse their mouth after use of an inhaled corticosteroid to reduce the risk of oral thrush and fungal infection that occur with inhaled steroid use. So now the other pharmacotherapy options for COPD. And these ones are used not really routine add-on, but more if the patients aren't responding to max therapy. So you'll see biologics like ensifentrine and long-term azithromycin. They all have in common is that there were patients with those persistent COPD exacerbations despite maximum inhaled therapy, which means that, LAMA plus LAMA, and when appropriate, the ICS use. What medications you who may have been used in the past for COPD, but we need to avoid according to current guidelines? First, theophylline and IV aminophylline. These agents have not been shown to reduce COPD exacerbations, and they come with a narrow therapeutic index, significant side effects, and drug-drug interactions. All major red flags from a pharmacy standpoint. So second, OTC epinephrine products like Primatene. These are not indicated for COPD-related shortness of breath and can give patients a false sense of control when they should be on the medications that were indicated for COPD in the guidelines. And some practice pearls highlight key steps for safely managing COPD inhalers. First, start by using barcode scanning and other verification tools to prevent mix-ups, especially as you've seen from the medications I described earlier. A lot of them look similar. Mix-ups do happen. Be sure to discontinue unused prescriptions for COPD so patients don't accidentally double up on meds. Provide accurate directions and billing, and clarify vague instructions like inhale as directed. Inhalers tend to be frequent targets for audits, so clear documentation is essential. Attach appropriate auxiliary labels to note important details such as unused dates after opening, and make sure patients rinse mouth out with water after using inhaler. Okay, so let's talk about how we can help improve COPD outcomes beyond medication usage. Other fundamental measures to improve COPD outcomes include things like smoking and vaping cessation if needed. Ensure patients know that it's never too late to quit smoking. Also, update vaccinations if needed, such as flu, COVID, pneumococcal, and RSV vaccines. Medication adherence is a biggie. And it usually is one of the primary factors behind COPD exacerbations and hospitalizations. So, if they're getting their rescue inhalers too soon, it could be a sign of worsening COPD disease or not using their maintenance inhaler effectively, or they may need to be stepped up in therapy. And lastly, inhaler technique. Before I jump into this, let me ask you, what percentage of patients do you think use their inhaler incorrectly? The number may or may not shock you. Approximately 70 to 80% of patients make at least one critical error when using their inhaler. It's a big number. To me, it seems like inhaler misuse is the norm and not the exception. How do we fix this? think we'll talk about some of the most common mistakes people make when using their inhalers because even small issues can keep the medication from working as well as it should. One problem that's often seen is that the mouth isn't tight enough around the inhaler, which lets some of the medicine escape instead of going into the lungs. Another issue is when the tongue or teeth get in the way, blocking airflow without the person even realizing it. Inhaling at the wrong speed is also very common, which can both affect how much medication actually reaches the lungs. Don't forget that some inhalers need to be shaken or primed before use. So check the package inserts, things like that. Skipping that step can mean they're not getting the right dose. It's easy for patients to unknowingly use an empty inhaler. So checking the dose counter when available is the best way to track remaining medication. Now, back in my day, I'm going to date myself here, patients would say they use the float test, which involves placing the inhaler in water to judge fullness, is inaccurate and, like myself, probably outdated. Buoyancy depends on the propellant, canister design, and moisture, not how much medication is left. And also, different inhalers float differently, and submerging the canister can damage the valve or to introduce moisture into that canister. If they're using a spacer, ensure it's used correctly so the medication flows the way it's supposed to. Finally, your body head position matter more than you might think. Sitting or standing upright with the head slightly tilted can help the medicine get deeper into the lungs. Keeping these things in mind can make a big difference in how well the inhaler actually works. Okay, so what about other things? So, looking at disease drug interactions. So, first, those non selective beta blockers like propranolol can worsen bronchoconstriction by blocking beta 2 receptors in the lungs. When possible, there should be a recommendation to switch to a more selective option like metoprolol. The other key class to watch for is opioids, things like oxycodone, especially when they're combined with sedatives. They can suppress respiratory drive, which can be a huge issue in those with COPD. All right, let's go and get back to our hospital patient, Patty. There's definitely more than one thing wrong with this. So she's using her short acting inhaler, her rescue inhaler, too often. She wasn't using her maintenance inhaler often enough. And she was on propranolol, which is a non selective beta blocker, which could be having issues with her breathing. She also smokes about a pack a day, in which smoking cessation would be recommended to her. And for more information on COPD, check out our resources on our website. Inhale medication for COPD and managing COPD goes over more on guideline changes and how treatments stack up.
Thanks for listening. We hope today's episode gave you practical insights you can use right away. Now that you've listened, pharmacists and pharmacy technicians can receive CE credit. Just log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. Listeners save 10% on a new or upgraded subscription. Just use code CC1026 at checkout. If you found this episode helpful, follow Clinical Capsules or leave a quick rating or review. It helps others discover the show. Even better, share what you learned with a friend or a colleague and let them know they can find the show on any podcast app or on YouTube. Thanks for listening. Stay sharp, stay current, and join us next time on Clinical Capsules.